many other hats, including having been won the Schwackman Award, which is the annual award from the North American Society of Pediatric Gastroenterology and Nutrition for an outstanding physician. More importantly, John is a crazy acrobatic pilot. He has like we have cars, John has planes. He's always tinkering and building, and as he said to me at breakfast this morning, spending his children's inheritance. But having been with John for many, many years, it's a great privilege to hear him speaking again. Not only is he a good guy, but he's also had some of the very seminal research in paediatric gastroenterology, in the areas of liver transplantation. John and I were at sort of the similar stage in the really infancy of liver transplantation, and it was fun to see how it's evolved over the years, John, isn't it? It's just been amazing how it's gone from this big deal to a routine procedure in many instances. John then, being a masochist as he is, took on intestinal transplantation, which is a whole new level over and above liver transplantation, but has had some very, very seminal work in the area of intestinal transport, intestinal sort of the disaccharidases and the development of the gut. So with that, John, I'd like you to deliver your opening address, or the address.
Thanks, Jeff. That's going to be a hard one to live up to. The one thing he did say is that that was absolutely true, is I'm his old friend. I wish I weren't so old, but you know, what can you do? I guess it's better than the alternative. They asked me to, I'm not sure what they asked me to do, but it had something to do with what happens to fussy babies and how do they end up, and so I put together this little talk for a number of reasons. One is because as a pediatric gastroenterologist, and I started practicing pediatric gastroenterologist as a lowly assistant professor at the University of Nebraska in 1976, and I've been doing it ever since. And actually did it for a couple of years before that as a fellow at UCLA, where Steve Wu was, and many of the rest of us at that time. And I one thing that I noticed is that pediatric gastroenterologists are often the dumping ground for fussy babies. If you have a fussy baby and the mother's driving you crazy and you can't fix it, the easiest thing to do with it is to send it to the poor pediatric gastroenterologist and ask him or her to fix the baby. So what I'm giving you is kind of a little bit of a summary of my own experience and some things I've learned from reading the literature, and some things I've learned from hearing other people talk about this subject. And all of this has sort of been assembled into my own clinical approach to fussy babies. And so that's what you're going to hear about today. The other part of this development of this talk relates to a project I did at Boston Children's, when we were all talking about, well, we need to do things the same way because we have 65 pediatric gastroenterologists at Boston Children's, and we all do things different. So we thought we'd try to standardize the approach. Vanderhoof, why don't you do fussy babies? Because nobody else likes it. And I said, well, I don't like it either. But I put this together as kind of a little clinical approach to how we should proceed with these babies. So I have to list my disclosures because that's what you do in academics, and these are a list of companies that I've either spoken for or consulted with. And if any of you in the audience are part of a company and you'd like to get on this list, the price of admission is surprisingly low. So please see me after the talk. So the first thing that I want to talk about, and this is really important, and I say it's important because when you see a fussy baby, a baby that cries and has no other problem but crying, I think this is something that I use to talk to the parents about. And if they can understand this, they can understand a lot of what's going on with a baby. And that is, why do babies fuss and cry? So if you think about it, most mammalian species, well, except for the marsupials, I guess, they're sort of born a lot more mature than humans. So a human baby, when it's born, can't do anything for itself. You know, it can't feed itself. You know, it can't move. It can't go anywhere. It's totally dependent upon its mother and other caregivers to take care of it. And it can only do one thing. It can't talk. It can't gesticulate. It can't do anything except cry. And all of its needs and everything it communicates can only be done by crying. So when the baby needs something, when it feels lonely, when it feels insecure, when it's hungry, when it has pain, whatever communication that baby has to do, it has to cry. And this was how babies survived, because back when our genetic makeup was developing, babies did that because otherwise they would starve to death. You know, they could communicate with their environment. So I think the mother, who obviously doesn't understand anything, she cries when something hurts, so she assumes the baby cries when it hurts, or you know, if it's uncomfortable or whatever. That may not be why it's crying at all. And moms have to understand that this is the baby trying to communicate with her and saying, hey, I want something, I want you to do something for me. It doesn't necessarily mean there's something wrong. It's a communication issue. And I think if you can help moms understand that, that will go a long way to when we go to the end of the talk, and what do we tell the mothers, and how can we help the moms resolve this problem. So what I want you to do, first of all, is look at the date that this thing was published. Down there in the bottom it says Pediatrics 1954. So this is not really new stuff I'm showing you here. And what it shows is the hours of fussiness in babies. And these are normal babies that cry. I mean, just like a normal baby. And you notice that most of them are crying in the evenings, and they don't cry during the daytime. Why do they cry in the evenings? I don't know. I could guess that you know, maybe it's a time of insecurity or a time of discomfort or whatever. But for some reason, late in the evenings, babies often cry. This is normal. This is what they do. And I think it's helpful for you as a clinician when you evaluate a baby and trying to figure out, you know, is there some pathological condition here, or is this just a normal baby that cries a lot? You know, look at the pattern and see if it fits into that group. Kind of interesting to note also, and this is a much newer survey of fussiness, and it looks at normal versus abnormal fussy crying babies to see how long these usually last. And as you can see here, and these are data derived throughout the developed world. This isn't just U.S. data like the other study I showed you, but these were collected in multiple countries and very consistent across the world. The babies are the same, and by 5 to 6 weeks is sort of the peak crying period, and then it starts to taper off. And by the time you're 3 months old, babies don't cry so much. So this is just the normal pattern that you see in normal babies for crying. This is a little graph I like, and I dearly wish I had this printed on the wall in every clinic room where I see patients. You know, it's nice that we have nice picture of the gastrointestinal tract on the wall in the GI clinic so I can show people where the organs are and whatever. But this, I think, would be a lot more useful. And so this is a curve that shows crying at different ages, and it shows how some babies cry more than others. And I like to tell the parents who have a baby that cries a lot, see if this thing, that you know, if you're lucky, you're going to have one of these babies that doesn't cry very much at all. But statistically, for every one of these, there's going to be one of these. And unfortunately, Mrs. Jones, you have one of those. And so you can kind of relate to that some babies cry more than others. And this can be a very, very normal phenomenon. The good thing is by 3 or 4 months, it sort of stops. And you can kind of say, you know, there's light at the end of the tunnel. This is going to be a while. And these parents need a lot of hand-holding. You know, these are the kind of people that you say, well, come back in 2 weeks or come back in a month and check the weight. Oh, yeah, your baby's doing fine. How's the crying going, whatever, and reassure them and get that anxiety level down as low as you can. So what happens? Do these babies turn out to be abnormal, these babies that have excessive crying? And the answer is no. By the time they're 3 or 4 months old, they're fine. They gain weight normally. They don't have more allergies than normal kids. They don't cry more than normal kids. They don't have behavioral disturbances. Some of them have little temperament issues, but usually not significant. They sleep fine. They react normally. They're normal. So you could tell the mothers the babies are going to come out normal. Well, what about babies that do this longer? Now, you'll see some babies that'll do this, they're still doing it 6, 7 months. These babies maybe not quite so normal. You know, they're more likely to have what we would call regulatory issues, difficulties in controlling themselves and how they react to things in their environment. You know, some of them the ADHD kids, and some of them just abnormal behavioral things, just being difficult kids. My brother's kid reminds me of these. They just kind of are. He's only got 1.5 years left, and he gets out. Some of these kids have a little more trouble. So if you've got one of those, doesn't mean there's anything pathological going on. It just means that he may be difficult. So here's the problem. It's a problem for the parents. It's not a problem for the baby. Baby's going to be fine. The parents may not be so fine. And there have been a number of studies that have shown that this kind of this excessively crying baby can disrupt the family and harm the relationship, and lead to relationship problems and divorce and stress within the relationship. And that's where I think we as pediatric gastroenterologists or pediatricians, and I think probably more the job of the pediatricians, we kind of have to look for these things and be aware of these, because this is one thing we can do, is to try to help alleviate these kinds of problems with the family. I mean, you try to look, how can you help? You can't make the baby quit crying, but maybe you can prevent the parents from having a disruptive marriage or something like that. And I kind of like this little vicious circle diagram here, because it sort of describes what's going on with these kids. The baby cries because he needs something. The crying increases the anxiety of the mother because she doesn't know why the baby's crying. So then she becomes more anxious. The baby perceives the anxiety. What's wrong with my mother? Why can't I fix this? What's wrong? And the baby cries more. And then the mother gets more anxious, and her anxiety increases, and she gets tired and run down because they can't sleep. The parent, they'll come in and say, "My God, I can't get any sleep. This baby cries all night." I don't know how many times you've all heard that, and I'm sure you've heard that many times. And any kind of stress that's in the family is going to feed into this, and this whole situation is creating more and more stress, and this is disrupting the family, and it puts the baby at risk for shaken baby syndrome. And so the one thing that I would suggest that you do in this environment is to look and see if there isn't something that you can do to make sure there's somebody's not going to hurt this baby. You know, have you ever thought about it? Do you think there's a risk going on? Is anybody in the family going to harm this baby? So, the bottom line is, for the baby, not so much a problem if you look at the abnormal crying during the first 3 months. Colic is self-limited. Most of the time it goes away by 4 months. Usually no long-term ill effects. Occasionally a little difficult temperament that might persist a bit. But the real risk is the tired parents, the anxiety. I love that statement yesterday about how the lawyer or the physician or somebody who's usually in control, and this baby's got them totally wiped out because they're not in control anymore. That kind of a stress situation in the family makes the parents tired, anxious, and the risk then comes to the baby. So that's, I think, what we need to, as pediatricians, look for is the marriage going to hold? Is the relationship going to hold? And is somebody going to hurt the baby? The baby's going to be fine. So only a fit mother can help her infant. You got to help the mom de-stress and understand before she can take care of the baby. She can't take care of the baby if she's stressed out and anxious. And that's, I think, the intervention that can happen with most of these. So what more normally happens with these babies? And I like to say that there's always a reflex action that I see with pediatricians when they see fussy babies. And I want to talk a little bit about that. Because we're physicians, and at least in the United States, I think a pediatrician has 6 minutes with a patient, and that's all the time you got. What I just told you to do takes maybe 20 minutes, and you can't do that 20 minutes in 6 minutes. So how can I get this baby out of here? And I got to do something. And so the first reflex is this. Start the baby on a PPI or an H2 receptor antagonist. Now, I was around in the 70s when everything that was wrong with a baby started to be attributed to gastroesophageal reflux. And there were a few colleagues who I won't mention by name who I think did a lot of harm to our specialty by over-diagnosing and over-treating gastroesophageal reflux. And this trend just skyrocketed throughout the world, and every baby who spit up was thought to be abnormal. So what is reflux? Reflux is when the lower esophageal sphincter intermittently relaxes. There's a little muscle in here, and when you swallow, it opens up, and then it closes, and it doesn't open up again until you swallow again, and so forth. But if you look at that little sphincter, that little valve, it sort of undergoes little gradual relaxations and contractions all the time. And if the baby's intragastric pressure is greater than the pressure inside the sphincter, stuff is going to come up. So you think about this, well, why would the thing be engineered like this? Well, one reason is if the baby happens to get overfed, it's going to reflux and regurgitate and get rid of it. So, that might explain part of why it does that. this unfortunately persists into adulthood, and there's some of us that when we get old, we have to take these drugs because we have heartburn or esophageal discomfort all the time. And if you've ever been pregnant, you probably remember how much things hurt when you ate because you had gastroesophageal reflux, because interestingly enough, the placental hormones will actually cause relaxation of the lower esophageal sphincter. They always, the obstetrician will always say, well, the baby pushes on the stomach. No, there's actually hormonal relaxation of the sphincter during pregnancy. So this is an issue, and because we as adults experience discomfort when we reflux, we naturally assume that the baby is going to also experience discomfort when it refluxes. Well, it turns out that doesn't happen. So I like this study. There's been several studies sort of similar to this one. This one by Susan Orenstein was I think the first one. And Susan took a bunch of babies that were fussy and crying and irritable, and put them either on a potent proton pump inhibitor, lansoprazole, or a placebo. And basically what she showed is that there was no difference in how much the baby cried, and no difference in how much the baby spit, and no difference in the baby's feeding difficulties on lansoprazole or off lansoprazole. The placebo group was the same. So these babies were totally unresponsive to acid suppression. Now, there was something that was significant. Anybody know what it was? Probably, well, Neil knows what it was. Anyway, what it was the babies that got the lansoprazole had more infections. Why did they have more infections? Both gastrointestinal and respiratory, because the function of the gastric acid isn't to help you digest food, it's to kill pathogens. So you took one of the baby's main pathogen defense mechanisms away by putting the baby on acid suppression. So you actually did harm for this baby, and no good, no improvement. Now, I will tell you that I don't know that this was in the paper, but Susan told me once that anytime she does a study like this, and she's done many of them, she always puts the babies on Nutramigen for 2 weeks before she enrolls them in the study. And the reason she does that is to exclude all the allergic babies. So these were non-milk allergic babies, and I think that's important as we talk a little bit more about this. So here's another study that I like, basically because it showed that, and this was done with pH studies trying to see if babies refluxed when they were crying, and there was no correlation between reflux and crying. When the baby cried had no relationship at all to when or how much it refluxed. So and the same answer looked at it in a totally different way. And I put this in here because one of the things that I heard from one of the other attendings in Boston, which I'd never heard anybody say before, is, oh, the baby's arching his back, that means he has reflux. And I'd never heard that. Maybe some of you have heard this. I'd never heard anybody say that. So I found that in fact, there was, in this study, no correlation between back arching and reflux. In fact, the person who wrote the paper said, you know, if the baby's arching his back doesn't correlate, if you want to look for reflux, look for somebody who spits up all the time, which sort of made sense. So what I've done here, and I've taken a long time to do it, because I think this is one of the real problems with medicine nowadays, is we don't put fussy babies on PPIs or H2 receptor antagonists, because A, it doesn't work, and B, it does the babies harm. So, and I'm very happy to see that now in the U.S. this is starting to take hold and people aren't doing that anymore. So, reflex number 2, change the formula. Or in the breastfed babies, change the diet. So this isn't totally a bad reflex. It's a reflex that may actually get you somewhere as long as you take a good history and try to figure out what's going on. So let's talk a little bit about that. One of the first things that I see pediatricians do is they say, oh, maybe the baby's lactose intolerant. I should put the baby on a lactose-free formula. And this then gets to a discussion of, does lactose intolerance occur in little babies? And the short answer is no. And maybe let me explain a little bit about this. I have time, don't I? I'm okay. Yeah, okay, plenty of time. All right. So if you look at what happens with carbohydrate absorption in babies, for a normal physiologic baby, and remember, all of our babies are designed to be breastfed. That's how we evolved as a species. And every baby, when it comes out, it can digest lactose. It has the lactase enzyme. And that's because the carbohydrate, most of the carbohydrate that's in the breast milk is in the form of lactase. So the normal thing to do, if you're a mother, is to gradually, over the first 3 years of life, wean the baby off of breastfeeding and onto other foods. So this is what's happened for the past several thousand years with our evolution. That's what people did. Now, if you think about this, and go back several thousand years ago, what one thing in our diet was the most precious? Protein. You really need protein, and we didn't get enough protein. So conserving protein was a big deal. So why would you, as a human, waste protein making an enzyme that you didn't need? So that after the baby's weaned, there's no need for lactase, because the only place it was present in the diet, well, lactose was present in the diet, was in that milk. So we started to shut that gene off, and the people that could do that had a selective advantage because they had other uses for the protein, and they were able to conserve protein that way. Then some people figured you could milk cows and drink that and get protein out of that milk. So there was a certain subgroup of people that were selected out to be lactase persistent so they could drink this stuff later in life and get protein that way. So we have two populations in our world. One is lactose malabsorbers that start around 3 years of age and become clinically symptomatic at about 5 or 10 or 15 years of age. And then we have those with lactase persistence that we can drink the stuff as long as we want. The important thing here is obviously little babies are all lactose tolerant, and none of them are lactose intolerant. And if they were, up until 100 years ago, that would have been a lethal mutation. So we don't see it. Now, having said that, you can buy a lactose-free cow milk formula and feed it to a baby, and under the assumption that the baby's lactose intolerant, but it's not. So no point in doing that. So this little paper here was actually a very old study that was published fairly recently by a colleague of mine, Colin Rudolph, who found these data somewhere and said this needs to be published because people don't understand that. Put that out there so that we would understand that putting fussy babies on lactose-free formulas does nothing. And so it's just like the PPIs, it doesn't work. That's if you do it in a placebo-controlled environment. Another just graph of the same data. It didn't work. It doesn't make any sense to do that. However, having said that, switching formulas actually seems to work in these babies. And so I thought maybe I should tell you a little bit about that and perhaps a little bit about why it might work. So if you look at consumer marketing data, you'll find that even though only probably 5 to 7, I think it's higher than 2 to 5% cow milk protein intolerance, if you look at and throw in the non-IgE type of allergy, and I'm sure Professor Shaw will tell you all about this, it's probably a higher number than 2%, but it's certainly not 50% of babies allergic to cow milk. So about 30 to 50% of babies are switched because of some perceived symptom from one formula to another, and up to 80% of the parents say, gee, that made the baby feel better. Now, usually, gassiness, which actually usually means crying, or irritability are the main reasons for switching. This is one thing I've learned. Parents will come in and they say, my baby's gassy. Oh, does that mean he passes gas or it comes up the top? No, he just cries all the time. Or my baby's constipated. Does that mean his stools are hard? No, he cries all the time. Yeah. And so I've learned over the years that I have to quiz people out, because a lot of times when they tell you the baby's, or their older child, in fact, is gassy or constipated, what they're really telling you is they cry and they hurt. And so you have to elicit that. So then let's take this story a little bit further. This is a study that I did years ago. I used to be Neil Shaw, and I worked at Mead Johnson, and I had the opportunity, like he does, to make formulas and whatever. And we made this little formula called Gentilese, and it was kind of a neat little formula. It had a partially hydrolyzed protein in it, so the protein was broken down a little bit. It's not truly hypoallergenic, but it's from an allergenicity standpoint, it's different. It has a few other things that are helpful. And so we took this formula and we took a soy formula, which would also be a different protein, not truly hypoallergenic, but different, and fed them to fussy babies. And within 2 days, the babies got less fussy. And it persisted. It didn't come back. Now, if you look at these data and you say, why is this? Is this because the babies were allergic? Or is this, and you gave them not a hypoallergenic formula, but a different protein, and so they transiently improved? Or is this placebo effect? And the answer is, I don't have any idea. But the stuff sure worked. And it gave the opportunity for the parents to switch to a formula that was pretty physiologic for the baby and seemed to work. Same thing with the crying. Interesting observation. Wish I had a better explanation for it. I do know how to figure it out, but we didn't ever do that. Okay, so I think I said a possible explanations: allergy or placebo. So could this be an allergy problem? So what I want to do now is talk to you a little bit about fussiness, irritability, and milk allergy. And so this story goes back into the 1980s when these folks in Sweden raised the question as to whether or not cow milk protein allergy could cause colic. And so what they did was they took babies that were fussy and irritable, and they put them on either an extensively hydrolyzed casein-based infant formula. I guess I can say it was Nutramigen because it was the only one that was made at that time. And then they also put them on a soy formula, and then they went back and re-challenged them at a later date at 6 months and so forth to see if they were still allergic to the formula. And what they found was that a lot of these babies got better. Then if they went back and re-challenged them, a lot of the babies had reactions to milk, and a lot of the babies had reactions to both milk and soy. So the conclusion of that these investigators made is that some babies with cow milk protein, or some babies with infantile colic, are actually cow milk protein allergic. And that's a subset of infantile colic that before we didn't realize that this could be a problem related to milk allergy. The symptoms that the kids got when they were re-challenged with cow milk at 6 and 12 months of age were a little bit different. A lot of times they got other gastrointestinal symptoms such as vomiting and diarrhea, rash, and so forth. And a fair number of them also developed allergies to other foods by that time. So this was kind of an interesting observation because it was new and novel at that time, and I kind of refocused some of our thinking about cow milk protein allergy. And it also, this is the paper from which the statements of, you'll see on some of these extensively hydrolyzed formulas, they'll put on the can, relieves infantile colic, quote, when due to cow milk protein allergy. That was all derived from this paper. So then back in 1989, with a different extensively hydrolyzed formula, the same group of investigators did another study where they took the extensively hydrolyzed formula, and the extensively hydrolyzed formula spiked with some intact whey protein in it, so that it was actually, the smell of the formula and everything was the same. And in fact, when the babies had the whey in their formula, they developed more symptoms of crying, quote, gas formation, vomiting, and so forth. You can see how the data split out here. So reinforcing the fact that fussiness and irritability can be caused by cow milk protein. So what about breastfed babies? Interestingly enough, a lactating mother can actually pick up fragments of intact protein from the gut, engulf it, transport it to the mammary gland, and excrete it into the breast milk as an intact protein. Now, I was shocked when I learned this because I thought it doesn't make sense. Protein's supposed to be completely digested to dipeptides and monosaccharides and transported and then reassembled. But when a mother is lactating and when a mother is pregnant, this other system of protein absorption kicks in. Why does she do this? So I think the reason she does this is because the baby's gut needs to sample very, very small quantities of antigens in order to develop immune tolerance. And if you have that opportunity, the baby then can learn that this is a harmless antigen and I'm not supposed to react to it. The immune system learns to make that decision. And if you don't have exposure to that protein, the baby has no way of being able to develop that tolerance. So then you ask me, okay, well, why then do not all babies have cow milk protein allergy? if they're getting formula from day one? And the answer to that is, same thing happens in the amniotic fluid. These proteins are getting into the amniotic fluid and the baby's swallowing them in utero. So having said that, there are some babies who will develop allergic reactions to these dietary proteins. And these babies can also exhibit the same kind of, quote, colicky symptoms. And sometimes by taking them out of the mom's diet, you can make them better. And this was the only paper I could find where David Hill did this little study showing that if you put the moms on a hypoallergenic diet, the baby, in fact, did have a reduction in its symptoms. And I think we all, as pediatricians, we do that. Sometimes it works and sometimes it doesn't. So Jeff told me I was supposed to show pictures and talk about pictures and walk around because that was, am I doing, I'm trying to do that. No, okay. So this is a picture of a duodenum endoscopically of a baby with cow milk protein allergy. And you can see all these, these big lymphoid nodules here that some of them have a little inflammation over them and whatever. And I've begun to learn that endoscopically when I see this usually means an allergic baby. And there's surprisingly few pediatric gastroenterologists actually recognize this. But this is something that I've learned more and more to look for when I do endoscopy. But the reason I'm showing you this picture, if you think about it, a baby that has a small bowel that looks like that, whenever he drinks something or eats something and it gets into the small bowel, that's going to cause pain. And if you don't believe me, think about what happens when you get inflammation in your small intestine if you get norovirus and you try to eat and it hurts. You get this bad crampy abdominal pain. Same thing happens with celiacs. They quit eating because they get pain from the inflammation up in that part of the small bowel. Kids with Crohn's disease. Inflammation in the gut causes pain and discomfort and makes people not eat. And that's what happens with these milk allergic babies, and that's why you see these kinds of symptoms. And there's just, this is actually a colon, but it shows the same kind of inflammatory changes in a breastfed baby that has cow milk protein allergy. So you can, even in the baby that has, in getting these proteins in through the breast, can do the same doggone thing. So then how do you as a clinician tell which you have, a normal healthy baby who cries too much or a cow milk protein allergic baby? So I made this little picture, and I think when I go through talking to the parents, I look for these things. Are the baby's stools normal or abnormal? And abnormal can mean too hard, constipated, or very loose, or even blood. That will point you, abnormal stools, more to the allergy side. Poor weight gain. A colicky babies go fine. A baby with cow milk protein allergy, because the small bowel looks like that, they didn't grow so well. Feeds poorly, the allergic baby. Because they start to eat, they get discomfort and they quit. And then after a few minutes, they'll want more because they feel hungry and they're getting these cramps and they can't tell, and then they try it again and it makes the pain hurt and they push away. And you see that kind of a poor feeding pattern in the allergic baby. Cries after eating, more commonly with a cow milk protein baby. Cries at night, more commonly with a colicky baby. Spits up a lot, allergic baby. The baby spits up a lot, and not because he has gastroesophageal reflux, but because his stomach doesn't empty very well. So the gastric volume builds up, the pressure in the stomach builds up, and when that valve relaxes, it comes up. It's the same thing, it's a different mechanism, but it looks like gastroesophageal reflux, and this is another reason why people think the PPIs will help. And the other one is distractible. If you have a colicky baby, and the pediatricians will say, well, if you take the baby and rock it like this and kind of make so it sounds like uterine blood flow, and soothes the baby, they'll quit crying. Another one, if you have a washing machine, you put the baby in an infant seat and set him on top of the washing machine, and they go like this. And the baby, he's happy because he's totally distracted, you know. Or you take the baby in a car, and usually this happens in the U.S. when, oh my God, there's something wrong with my baby. Let's take him to the emergency room. So they put him in the car, and he gets in the infant seat, and yeah, he's fine, you know. A milk protein intolerant baby doesn't do that because he hurts. You know, he may do it a little bit, but you know, that damn washing machine didn't make this pain stop, and I'm still going to cry because it hurts. So that if you kind of go through this with the parents, you can figure this out. And so what I always say, if the baby isn't growing well, if he has unremitting symptoms, if he has other symptoms other than just crying, then you think about the milk allergy. And if he has no other symptom other than crying in the evenings, it's probably a colicky baby, and probably doesn't make a whole lot of sense to try it. Having said that, a couple of weeks on an extensively hydrolyzed formula isn't necessarily a bad thing. So I think the important thing here is like all medicine, it starts with a careful history and physical. You have to figure out, of course, how you can do it in 6 minutes. But that's, I think, what you have to do. Establish a differential diagnosis. See what fits. Is it a milk allergic baby? Is it a colicky baby? Or does it have one of these other more rare things that might be causing trouble? And figure that out and test appropriately. And then once you've established the diagnosis and you're convinced, you have to tell the parents, this is what it is. No equivocation. Because if they sense you don't know what's going on, the anxiety level is going to go right back up again. Does the history fit? Are there any red flags? You know, a lot of us think about when we deal with these functional disorders, and I think we're going to hear more about that today, functional gastrointestinal disorders. We look for red flags as pediatric gastroenterologists, and that's how we tell if there's something to do. And of course, is the baby at risk? Remember the risk of the damaged baby. So other things to think about: metabolic, central nervous system diseases, careful developmental assay, developmental examination to see if the baby's falling behind. Is there anything going on in the environment that might be messing this thing up? You know, figure all of that out. Then consider if you need to do any kind of dietary restrictions. If the baby has colic, that's when we go into explaining why babies cry. And reassure the parents, but this is where you have to be very positive. This is what your baby has. This is what we're going to do about it. No equivocation. Don't give them the sense that you don't know what's going on, because that will increase their anxiety. We've looked for these other things. You know, there's nothing to suggest that there's anything else going on. Explaining the swaddling, the soothing, the repetitive stimulation. You know, one mother said she wore out 3 vacuum cleaners before her baby quit crying because the only thing that would make it better was to turn the vacuum cleaner on. You know, so and little things like that. I put in here some. If I have time, I'll just talk about other potential things that you can do, and then the final thing is make certain that the parents take you seriously, and that you give them the impression that you really care about it. Because and this is true with all functional gastrointestinal disorders, is if you give the parents the impression that this isn't a big deal, go away, there's nothing wrong with your kid, that's not what they want to hear. The kid has a problem, they brought a problem to you, they want you to fix it. It's a real thing, and you have to treat it like a real thing and really help it. So if there's any other things that you can do, what are they? Well, probiotics. This is Lactobacillus reuteri DSM 17938. Now, I put this in here because if you're going to use a probiotic, you have to make sure that you got the right strain. And hopefully, when Professor Kanani talks about tolerance and allergy, he's going to talk to you about Lactobacillus GG, which is a very specific strain of probiotic that's been shown to work in milk protein allergy. And if you don't have exactly the right strain, it won't work because all the strains are different. So here's one very specific strain of Lactobacillus reuteri, which seemed to work in breastfed babies. However, another study done that looked at a combination of breastfed and formula-fed babies with colic, and it didn't work. So what's the truth? I don't know, but I know there are some people that try this in breastfed babies, but you know, you got, like you say, you got to make sure you got the right strain if you're going to use a probiotic. Oral hypertonic glucose. There's a few papers that show that giving small quantities of oral glucose solution will make the baby's colic better. The problem with this, of course, is you can't do it instead of feeding the baby because obviously he's going to lose weight. So it's just, it's just something that occasionally, so well, you can do this occasionally if it gets really bad, and maybe it will help. Complementary medicine is always, everybody always wants to look at things like probiotics, herbal tea, different kinds of supplements and whatever. And there's very little indication that any of these may work. I think there was one study with a certain herbal tea that showed some benefit, but not very good studies and not very much data. And even chiropractic. There were a few studies that showed that chiropractic worked in babies with colic, but the only one of the studies that was actually done in any kind of a decently controlled fashion showed no benefit. So I think probably doesn't work, but it has a placebo effect. So there really isn't much here to use. So I think you're kind of back to the same place where we were before. Is this a colicky baby? Is it an allergic baby? How do I tell the difference? What do I do? And then let's try to get that parental anxiety under control and get that mom settled down so she doesn't make the baby crazy and the baby doesn't make her crazy, because that's actually what's going on here. Make sure they understand that the baby's not sick. Point to the normal growth and development. See how your baby's growing normally. This is fine. Your baby's going to be just fine. He's just expressing himself. You need to not overreact to this thing so much. Talk about that curve, that cry curve, and how it goes and how it ends up and how things are going to get better. Talk about how crying can be reduced by changes in how the infant is handled. I mean, I can't tell you how many times I see these mothers holding this baby out and screaming and yelling. And he says, "Give me the baby." And you're kind of, the baby's fine, Give the baby back to the mother. So, you could show them that and kind of help them understand how that works. What was yesterday's? I thought another great comment. Don't pick the baby up every time it wiggles and screams a little bit. Let it cry a little bit first. Let it learn to soothe itself. And that a lot of times will help. These moms are, because of their anxieties, they're overreacting to this thing. They're just making themselves crazy about it. So anyway, I guess we have, I do have an airplane, questions after this thing. So I won't answer any questions, and I hope you found this interesting. I'm happy to give this talk here because I'm in Indonesia. Nobody's going to refer me another fussy baby here, so I won't give this talk in the U.S. Thanks, Jeff.
I'd like to thank John. I think this has just been, I think you've been exposed to a masterclass from a senior clinician. And it's wonderful to see how years of experience can be just put into place for what is a common problem, but with a very simple solution in many respects. And so you've just witnessed a masterclass of clinical medicine in that regard. It also reminds me, I've heard too, that when you're talking about the baby when they're first born, there's a growing sort of population or trend on the internet talking about the fourth trimester.
Yeah.
We were actually born too soon. And in fact, you could probably blame DHA and things when in the Rift Valley, when the brains got too big, the babies wouldn't come out through the pelvis. Well, they should be here for another 3 months. If you think of all these issues, they actually occur in those first 3 months of life mainly. And if we were born at 3 months of age, in fact, many of the problems wouldn't have happened. So we're born too soon. And it's never going to change, because I don't think the ladies would really like to go sort of 15 months of pregnancy, would you? But that's also... And the other thing, just to comment too, is that you talked about the protein sort of preservation. I always think too, I think of it in terms of the reason why there's a relative lactose malabsorption in the infancy is because it's feeding the microbiome in the gut and helping the microbiome to develop. So this is another, nature doesn't make a mistake. So anyway, John, I'd like to thank you and give you the obligatory Botox photo.
Oh, wonderful. Yeah. I use Botox, but not on the face. But